Hello, everybody, and welcome to Five Questions with Sarah Downey. I'm Sarah Downey, and I'm the president and CEO of the Michael Garron Hospital here in East Toronto. And it's my pleasure today to invite and welcome Mark Pham, who's the vice president of programs at this hospital, and Dr. Carmine Simone, who is the chief of surgery and the medical director of the Surgical Health Service, here to talk to us a bit about what has happened to our clinical programs during COVID. So welcome, Mark and Carmine.
Thank you.
So my first question is, when COVID-19 began, Michael Garron Hospital had to ramp down its services. Why did we do it, and by how much? Mark?
Yeah, I can start with that, Sarah. So in mid-March, all hospitals across the province received what was called Directive Number 2 from the Ministry of Health, which asked everyone to ramp down services, specifically any kind of elective care across the organization. That included our elective surgeries and care across the organization. And what that meant for us is we reduced down to less than 25% of our surgical volumes, about 50% of our emergency volumes and inpatient volumes that we saw in the early days of COVID-19, and really focused on what was essential care. For our ambulatory clinics, that meant we went from about 10,000 visits in person every single month at the organization to very few, only emergency visits. And with that, as we'll talk, a real shift to virtual care. So it was a real significant decrease in volumes to respond to the potential pandemic, and really closely coordinated with the Toronto region of how that ramp down needed to occur.
Great, thanks. And I guess, Dr. Simone, that's a lot of delay in care. Do we know how many patients are waiting now for care, and what types of patients are they? What are they waiting for?
So that's always a very important question that we're getting from our patients. And I do want to say that the patients that need surgery the most, so the emergency cases or the urgent cases, are still being dealt with, and they are still getting access to the operating room. And for the urgent patients that need their heart catheterizations, they're also getting access. But about 80% of what we do, 75 to 80% of what we do is elective surgery. And that accounts for about 500 to 600 elective surgeries, about 500 or so cataract operations, and about 150 heart catheterizations. And so there is a significant amount of backlog and patients that are waiting for their care. We do have a plan, however, to address those cases that have been put off or canceled, and we are making some progress. As we heard, we are slowly ramping up. So in June, we are already addressing some of the more urgent of those cases that were canceled, and we have a plan to start addressing many more of those over the course of the summer, July and August.
And how long do you think it'll take to catch up, Dr. Simone?
So that's a really important question that is going to be hard to completely answer. We are confident that the most urgent cases and the ones that have been waiting the longest, we feel we're going to be able to get to over the course of the summer. And we think that we have a pretty good plan to address the rest of those cases over the course of the fall. And we're very confident that we're going to be able to deal with all of the backlog over the course of the next year.
Great. So, Mark, getting back to regular business is going to be tricky. How do we do that safely? And I know a lot of our surgical staff are redeployed to different parts of the hospital to help out. How are we going to get everybody focused again on doing procedures like surgery or heart catheterizations?
Yeah, thanks, Sarah. Maybe I can start actually first by just thanking everyone who has been redeployed. I know we have over 50 to 60 people every single shift getting redeployed across the organization, and many from our surgical and cardiology and other programs. So big thank you to everyone for your amazing efforts. It's what's enabled us to do all this. Getting back to business is going to be a really kind of thoughtful process of how we do this. And it will mean that as we start to return to our normal surgical volumes and kind of work through a gradual ramp up, people will go back to their home units. But as folks go back, we're going to have changes to how we work. So as you said, we're going to be really thoughtful about what does safe quality care look like. It may mean changes to some roles in terms of how folks work. It may mean introducing new roles to help augment the kinds of care we deliver and how we work. But it will be a kind of really thoughtful, gradual return to everyone back to their home units and really focusing on getting our surgical services and other procedure volumes back up in business.
Great. So tell me, Dr. Simone, we still have COVID in our environment. And so what is different in this new normal when we have to do procedures, do operations, see ambulatory patients? What is the new normal like, and how is it different than it was before?
So one of the things that we're trying to use this whole COVID pandemic for is to learn how to deliver better care in general, not just during COVID. And we've learned quite a bit. And so the new normal is being defined and being redefined every week. But right now, one of the biggest things is going to be physical distancing. And so we do know that the number of patients at any given time and how many patients per hour we're going to be seeing in the ambulatory care settings is going to be different. And that we see that being a new normal for the foreseeable future. The other things that we've learned and we've heard loud and clear from our patients and from caregivers is that virtual care is here to stay. And I think we're very well equipped to be able to make that a permanent fixture in a lot of the things that we do, like clinic visits, like office-based visits, and care at home for patients that are being discharged after their operation. Screening patients is going to be something that's going to be here for the foreseeable future. So making sure that patients are self-isolating, making sure patients are not symptomatic. And for those patients that need it the most, being able to have access to swabs to make sure that they're not COVID infected before they come to the operating room or to an ambulatory care setting. And I think those are probably the biggest changes that we're going to see for the foreseeable future. But like I said, what's really exciting about all of this is that we are learning about all kinds of things to make care better. And we're looking forward to hearing more from the community and from our caregivers to see how else we can change.
Great. So Mark, is it possible that we'll have to ramp down again?
It is possible. I will say our commitment as a hospital is to our community to make sure we're maintaining emergency care. And so as part of our coordination with the rest of peer hospitals and our community partners in Toronto, it's making sure we keep to that commitment. And so if we saw another wave of COVID-19 as there's some concern down the road, we would be thoughtful about ramping back down services to maintain that emergency care for COVID response. But ramp down may look a bit different. We're really thoughtful about how do we not ramp down as much as we had to before? How do we shift more of our care virtual? How do we learn from this first wave of COVID to really make sure we can maintain as much service as possible? Because we know there's an impact for patients who have been waiting for surgeries and have been waiting for other procedures. So we're going to be really conscious of what that looks like to make sure we maintain as much as possible. We monitor that every single week. So across leadership, clinical and administrative leadership of the organization, we look at this every week in terms of what our risks are, what our ability to ramp up further is, and we coordinate with the Toronto region as well. And it's actually at a Toronto region level that decision around how quickly we ramp up comes, and how we then make that happen locally is something that we discuss inside the walls at Michael Garron.
So it sounds like there's a whole system lens and approach to this, that it's not just Michael Garron Hospital ramping up or ramping down. It's really in the context of an entire system.
That's absolutely right.
That's great. Well, listen, thank you both for taking time out of your busy days. I'm sure you probably have to get back and start delivering service to the people who've been waiting. It's been a really hard time for patients. We know that, who've had to wait. It's been a hard time for many of our surgeons who haven't been able to operate during this time. And I think we've understood what the impact has been and what the approach to recovery will be. And thank you for taking time to speak to our staff and speaking to our community about what's going on inside Michael Garron Hospital. With that, thanks everyone. We'll see you next time at 5 Questions.
Thank you.
Thank you.